From the JAMA Network, this is JAMA Surgery Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Surgery.
Welcome, JAMA Surgery listeners. This is Amalia Cochran, the web and social media editor for JAMA Surgery. And today I am speaking with Doctors Alex Santos and Ville Sallinen from the University of Helsinki on their study, the laser randomized clinical trial looking at quality of life and recurrence outcomes following laparoscopic elective sigmoid resection versus conservative treatment following recurrent, complicated, or persistently painful diverticulitis. Dr. Santos and Dr. Sallinen, welcome back.
Yeah, thanks for having us again.
Thanks for the invitation.
I'm really excited to have the opportunity to speak with the two of you again. We first spoke in late 2020 when the 6-month follow-up data from the laser trial was initially published. And so this is a great opportunity for me to learn more about your work. As I read through this manuscript, I quickly realized that there was a substantial amount of treatment crossover that occurred by both 12 and 24 months for those patients who were initially randomized to conservative or medical management. This obviously has some implications for both the statistical analysis and the clinical significance of your findings. Could you please tell me more about your decision to perform the post hoc per protocol analysis of the data? Why was this important?
Yeah, well, we noticed that at 2 years, there was no longer difference in gastrointestinal quality of life in the intention to treat analysis. And we wondered if that could be explained by the fact that in the conservative treatment group, a substantial amount of patients had crossed over to surgical treatment and were therefore reporting improved quality of life due to surgery, actually. And the fact that there was still a difference at 2 years in the per protocol analysis makes this a very likely possibility.
When we looked at the data in more detail, it was evident that the patients who had lower quality of life were seeking surgical options. And therefore, the patients with lowest quality of life were actually the ones who crossed over to surgery. So after surgery, their quality of life improved, which in a way diluted the difference between the groups in the intention to treat analysis. And this is the reason why we wanted to perform the per protocol analysis, kind of in order to mitigate the bias caused by the crossover.
In light of that decision, do you think readers should weight the importance of the intention to treat analysis differently than the post hoc per protocol analysis when they're looking at your findings?
This is a good question. I think they should weight it a little bit differently because there is a big amount of patients who are crossing over from conservative group to the surgical group. And then it might be that the per protocol analysis might give a more realistic picture of how the patients are actually feeling.
I also was really curious about, with regard to what you mentioned about the crossover being so great between the two groups, were you all surprised by that at all, or was it not really a surprise to you?
Yeah, in regards with the crossover rate in our laser trial was actually lower than what we anticipated. It was about every 5th patient randomized to conservative treatment underwent surgery within 2 years. For example, in comparison, the crossover rate in very similar trial, the direct trial, was about 50% at 5 years. So actually, we were positively surprised that the Finnish patients were very committed to the allocated randomized group.
Yeah, and concerning recurrence rates, I was not really surprised because we knew from the literature that even though the possibility to have a diverticulitis in patients with diverticulosis seems to be under 10%, however, if one episode, the probability to have another one increases, and that seems to happen after each episode. So since the inclusion criteria for most of our patients was actually recurrent diverticulitis, we knew that most likely, if followed long enough, new episodes were likely to occur. So not really so surprised about the recurrences rates either.
That makes a lot of sense. Thank you for that clarification. What ideas do you have regarding the fact that there may not have been a difference between medical and surgical management for the patient's quality of life at 2 years?
Well, one possible explanation would be that since the crossover cases affect the reported gastrointestinal quality of life in a positive way. And this might mean that patients that were previously suffering the most from recurrent diverticulitis and ongoing pain, for example, are now free from that and therefore report better gastrointestinal quality of life results.
Yeah, in addition, those patients who did not actively seek crossing over to surgery in the follow-up had already better quality of life at the baseline, and they were seemingly happy with the allocated conservative treatment. And one could then therefore argue that those patients might not even benefit or need surgery. I mean, these are both sides of the coin, and the patients who cross over and get improved quality of life and the patients who already have fairly good quality of life to begin with, these both affect the outcomes of the intention to treat analysis, where no difference at 2 years were seen. So that's why we think the per protocol analysis are actually very important.
What are you the most excited about sharing from this longer term follow-up data on your patients with all of us who are your readers or your listeners right now?
Yeah, well, we think that surgery does seem to affect patients' gastrointestinal quality of life in a positive way, and that can be seen by the reported test results and can also be very clearly seen by the amount of diverticulitis episodes. And I think that's the exciting thing to say about it.
What about the new study or the expanded study with the longer term follow-ups now have I not given you a chance to talk about that you would like to share with us?
We are very excited to share these 2-year results, but maybe we can just, point to the fact that the trial is actually still ongoing and we are still following up the patients. And it will be really interesting to see how the results will look in even longer follow-up. We have pre-specified time points at 4 and 8 years from randomization, and it will be really interesting to see how the results of those will look like.
I was really curious as to if the findings that you have to date have impacted your discussions that you are having with patients who have recurrence of their diverticular disease.
Yeah, in fact, they have. I think that our research is actually quite illustrative of what happens to this subset of patients. There seems to be an improvement in quality of life after surgery, but we also have patients doing just fine in the conservative treatment group that were not subjected to surgery. So if a patient is motivated to surgery, I feel comfortable in advising him or her to go on with it. But if the patient has second thoughts or is in particular danger of having anastomotic leakage following surgery, I think the decision not to operate might be for that specific patient the very best option.
I echo Dr. Santos here. I mean, these results give clear figures that can be discussed with patients and also sets expectations what can be achieved with surgery. And the results also gives a possibility to trial conservative treatment first, because it was very safe based on our results. And then after crossover to surgery, if the patient wishes so.
Dr. Sallinen, you referred to the fact that, at least for your Finnish patients, that they seemed very willing to stay in the arm that they were allocated to in a way that almost was surprising to you. And I am thinking about this from the standpoint of generalizability of what you all are finding to other places, because I know that there are certain, fairly unique features to the Finnish healthcare system. And what I would like to ask you, if you are willing and able to address, is if you think that these results will be broadly applicable in other healthcare systems that are not nearly as organized as you all are.
Well, it's a difficult question. We have to speculate a little bit here. Actually, we've discussed in our previous interview that one of the things that we were surprised by was how satisfied patients were with the assigned treatment. and even those that were not doing objectively so well. So there might be a cultural element in here, which is for us hard to say how well can it be transposed to other countries. Concerning the Finnish healthcare system, well, we didn't really do that much other than follow up our patients, which I think it's a very easy thing to do or common thing to do in most developed countries. So I would say that our results should be easily replicated elsewhere as well.
Yeah, I mean, I think even though there were crossovers, the crossover rate was fairly low, but I would consider that more as a strength, because maybe in other places it would be patients would easily cross over to surgery more in the beginning, and then the results of the conservative treatment arm would be even more diluted. And with this trial, I feel that we get quite realistic picture of the benefits of the conservative treatment arm. And yet still we can show that the surgery improves the quality of life of the patients.
That makes a lot of sense, and I think actually provides a good transition to the last question that I have for you all, and that is it time for new clinical guidelines for the management of recurrent or complicated diverticulitis?
I think that actually current guidelines already point to the fact that the need to operate has to be made on an individual level, which I think is an accurate assessment. However, I think it should be more stressed that surgery is a good solution, especially for patients with diverticulitis, with recurrent diverticulitis, or symptomatic uncomplicated diverticular disease, now mentioned quite often, and that might actually significantly impair a patient's quality of life. So I think this should be actually more stressed in guidelines.
I also think that the guidelines are quite well balanced at the moment, but as they are recommending tailored approach for these patients. But I also think that now the recommendation for surgery can be made with stronger confidence. And with the laser trial, the inclusion criteria that we have used in laser trial, which was 3 or more diverticulitis within 2 years, that can also be incorporated to the guidelines and can be used as a threshold for offering surgery as a treatment.
I am incredibly grateful to get the opportunity to talk to you all again today about this work. I think it's incredibly important what you all have been able to do to help us look at diverticular disease, which is really one of the most common diseases that does have surgical implications. And so I'm really grateful for that. And I really look forward to your additional follow-up work with the 4 and 8 year data following randomization. Thank you both so much.
Thank you.
Thanks for having us.
This episode was produced by Daniel Morrow at the JAMA Network. The audio team here also includes Audrey Foreman, Marilyn Ferkalek, Lisa Harden, and Hannah Park. Dr. Linda Brubaker is the senior editor for JAMA Multimedia. For this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening.